Hey everyone, welcome back to PS Platypus. Today we're going to be having a look at some clinical skills. This time we're going to be having a look at the mental state exam and the mini mental state exam and talking about what those things are. So let's get started. So this is a bit of a summary slide set that's going to be going through a couple of topics. The first one is a mental state exam, specifically what the elements are, what it involves, some of the terminology that's used to describe things like thought, and then probably the most important thing that I encourage you to have a look at is the script that I've sort of put together, because when it comes to this section or this area of content, most commonly the way you'll see it being assessed, at least in the form of an OSCE, is you'll be given a video of someone being interviewed, and then you have to summarize the findings. And so the script can really help you to figure out how to plan what you want to say, and then choose the relevant elements you want to discuss and talk about them in your reporting back to the GP. The mini mental state exam is another area that's separate to the mental state exam, but is very commonly confused. They're very separate things. It's a questionnaire that tests for cognition. We're going to talk about what it involves, but again, you won't commonly see this in a practice OSCE. The reason being that it takes quite a bit of a while to get through this checklist. Instead, more commonly, you'll see it show up in the odd MCE, extended multiple choice question. And so I'd recommend you to have a look at the terms, understand what they mean, but then not worry too much about it being in the OSCE. And then we're also going to cover some useful resources that I found useful when I was learning this area, because it can be a bit confusing. I'll pass them on to you, and then you can use them to guide your own learning as well. And we'll talk about that at the very end. Let's start off with the mental state exam. So the mental state exam is essentially an exam of a person's mental state, and we examine it through a couple of important elements. So there's a commonly taught mnemonic, which is aseptic, which stands for appearance/behavior, which is sort of the first thing you notice before a person has even started speaking, and therefore it's the first thing that we actually look at in a mental state exam. Then you have speech, which is when the person starts speaking to you, and then you can sort of examine their speech. And again, we'll go into it a bit more detail in a second. You have speech, you have emotion, which is separated into affect and mood. We'll talk about how they are different terms and not the same thing. Perception, thought, insight and judgment, and finally cognition, which is not usually formally assessed. It's done most formally through a mini mental state exam, so a separate examination, the questionnaire that we discussed before. But we'll talk about how you can just comment on it generally anyways. Let's start off with appearance. So commonly when it comes to appearance, you'll often see in a video or in some sort of an interview, a person coming into the room, sitting down and then getting ready to have a chat with the physician. And you can comment on a couple of things, their age. So roughly, you won't have an exact number. Sometimes you might be given their exact age in the STEM. But if not, you can just comment on if they look young, adolescent, middle-aged, elderly, however you want to describe it. The ethnicity, Caucasian or otherwise, you can comment on that here as an Indian person. You can comment on that otherwise here. And their gender, right? Male, female, or non-binary, you can comment on that here as well. And finally, you can talk about things like clothing. And when it comes to clothing, you might be thinking, what else can you say besides they are well-dressed? Well, you can also comment on things like, is the clothing they're wearing appropriate? Like, are they actually wearing clothing that's appropriate to the context that they're in? Do they look disheveled? Maybe like some buttons are undone. Maybe you can comment on things like they're wearing a tie with the wrong sort of shirt. Like if they're wearing a sweater and a tie, that's not really things that you normally expect someone to wear. So you can comment on that. And then you can comment on things like grooming and hygiene. So that's like talking about, are they shaved? Are they, have they combed their hair? They appear like they're looking after themselves, essentially. Have they got a little dirt under their nails? Things that might indicate them possibly aren't giving as much attention to themselves, and which can also be linked to an underlying pathology as well. Then we have things like posture and gait. So if you happen to see the person walking into the room in the video, then you might be able to comment on things like a very slow posture, a very slow posture, a very staggered posture, whatever, or slow gait and staggered gait. And then posture refers to sort of how they're standing, as well as how they're sitting as well. Are they slouched over, head down, not making eye contact? Or are they very like upright in the chair, well engaged and looking at you in the eyes? That sort of comes more into the behavior domain as well. We talk about rapport and engagement. Is the person able to establish good rapport with you, or are you able to establish good rapport with them? And are you able to sort of keep them engaged in conversation and them, and that can sort of be done by looking at things like eye contact. Are they able to maintain good eye contact with you? And then we also have the concept of psychomotor retardation, which is essentially, do they seem slower than usual in their movements and their mannerisms, or do they seem more agitated? So you can even see the opposite with psychomotor agitation as well. Then we come to speech, right? Speech is when they finally start talking during the interview. It's kind of difficult because you're not only trying to understand the content of what they're saying, but also the way they're speaking as well. So it can get a bit tricky. And the great thing is often you'll be able to listen at least twice to get a bit, like on the first round, you might focus on a bit more of content. And then the second round, you might focus a bit on the manner or the way they're speaking. Or you might do a mixture of the two, whatever works best for you. But essentially, when it comes to speech, you want to think about what's the rate of the speech. Have they got a normal rate, normal rate, like normal speed essentially? Are they slow when they're speaking, or have they got pressure of speech where it's just sort of they're speaking very, very quickly, right? And you also want to comment on things like the quantity of speech. Is it nothing? Are they like not even commenting at all? They're choosing not to even talk to you. Is there minimal content of speech, or is there excessive content of speech? Is there so much talking about that it's hard to sort of keep them on track and keep them speaking about relevant things that you want to get from them. And then you also have like very basic things like volume, right? Is it quiet, loud, or is it just you feel like it's an appropriate volume? And that's something that you might pick up on as well. And finally, you come to fluency and rhythm. Do they have some sort of dysarthria? That's where like the instrument, aka the mouth and the tongue and all the vocal cords, have some sort of problem that results in the speech coming across unclear. So that can be in the form of a slur or a stutter. Essentially, you want to listen out for that because that can again point to a pathology as well. All of these things might seem like pretty not that important, but if you actually get a combination of these things and then put them together, you can often help diagnose the person with something, right? So on their own, obviously, it might seem quite minor, but then together they can form a constellation of symptoms that point you towards something. Then we come to emotion, and emotion is important because there's two ways you can get to understand someone's emotion. The first one is mood, and mood is what you report. Oh, sorry, other way around. Mood is what the patient reports. So mood is what the patient reports as being their state of mind. So you have to explicitly ask the patient, how they're feeling, what their mood is, however you want to ask that. Get whatever the patient says and report it in their own words usually. So if they're saying, I'm feeling down, you could say, the mood of the patient appears depressed, and in their own words, they said they were feeling down. It's often good to quote the person because it ensures that you've interpreted them correctly rather than misinterpreting what their words were for something else. And then affect, you could think of it as being a more clinical, scientific word, which is where you, the clinician, are reporting what you think to be your evaluation of their mood. And you can comment on things like the quality of the mood. So that's the actual type of mood they have. Are they looking depressed, anxious? And you can use multiple different types of words to describe the affect here. So it's essentially like what your view of their mood is based on the way they appear, the way they're talking, and what they're talking about as well. And then the intensity of their mood, like have they got a blunted affect where it seems like everything's a bit dulled in terms of their mood. They don't really have a great range of mood, and that's called restricted affect as well. And again, all these terms, you'll come to see examples of that in your practice sessions. So keep an eye out for what those things look like. And then we have congruence and consistency. That's a sort of minor thing I like to comment on is your evaluation of their mood, aka the affect, congruent or consistent with the actual patient-reported mood? If they're congruent and consistent, that's pretty regular, right? You'd expect the patient to have good insight into their emotions and know what their mood is. If they are inconsistent, it might mean that the patient lacks that insight, or they might be masking their true emotions because they are unwilling to face it or unwilling to talk about it to you. So again, you can see how it can become important whether or not there is that congruency and consistency. So that's appearance, behavior, speech, and emotion all done. We're now going to move on to some of the more content-heavy sections. So now we come to thought. I know perception is also on there, but we'll come to that later because thought has a bit more thought behind it, essentially. So thought has a lot of things within it. So the first one is stream, thought stream, and that's basically based on a person's speech, what do you think is the speed of their thinking? So that sounds a bit subjective, but based on how they're speaking, if they're speaking very fast, you can assume that they're thinking very fast as well. Like if they're speaking fast, coherent sentences, you can assume that they have a fast thought stream, right? However, if they're speaking very slowly, coherently, you can assume they have a slow stream of thought. But you might be sort of wondering how can you differentiate between the rate of speech and the rate of thought? Well, some ways you can differentiate that is, for example, let's say they're speaking very fast, but what they're saying isn't entirely coherent. That might mean that their rate of speech is fast, so they have a pressure of speech, but the thought isn't able to keep up. And so they're just sort of adding in random filler words or thoughts and ideas that don't necessarily correspond to thinking faster, but just speaking faster. I hope that sort of makes sense, but you can see how it can become more nuanced with that. But usually you'll just be commenting on the stream of thought as being pretty similar or indicated by the speech rate, essentially. And then when it comes to the form of thought, so the structure, there's a number of things that can go wrong with structure. So you can have people at the word level, essentially, having things like neologisms, which is like the word suggests, neo, new words, right? They're making these new made up words. And often I get confused by this because sometimes a patient will say a word in an interview, and because they're using it so confidently, you might think it's an actual word. But then you have a look in the dictionary and it's not even there at all. They've just made up that word entirely. And that's an example of a neologism, which can be hard to figure out because it's hard to know where your vocabulary ends and a new word is just pops up out of nowhere. And then you also have alliteration, which again, you can comment on, a person might be using a lot of alliteration when they're speaking, and it just becomes a pattern of the speech, which seems different to how people normally talk, right? And then you also have other forms of thought disorder, formal thought disorders, which is things like flight of ideas, where it's really hard to follow with the person. They're speaking and they're sort of going on different loops and different ideas, and it's hard to follow up with their chain of thinking. That's called the flight of ideas. And then you have things like loosening of associations and circumstantiality, which are very similar but sort of swapped around. So loosening of associations is where they sort of give you an answer to your response. So you might ask them a question, they might answer you, but then they follow that up with a bit of irrelevant information, and they slowly start losing the, I guess, the relevance of what they're saying, and it becomes more and more relevant. So that's called loosening of associations, where sort of each step along the sentences becomes less and less relevant to you. Then you have circumstantiality, where rather than going straight to the answer, they'll go on a whole loop talking about the circumstances, like the irrelevant info, and then get to the final answer. That's called circumstantiality. Then you have tangentiality, which is, as the word suggests, going on a complete tangent, going off topic, and not even really addressing the question at hand. You might ask them about their mood, and they'll start commenting on the weather, right? Which is you've not asked them about at all. And then you also have things like word salad, where they'll say random words that put together have no meaning, and therefore they're speaking very incoherent. They might say tractor, caterpillar, phone, right? Those three words don't really have much sort of coherence put together, unless you see some coherence in it. But that's what a word salad is. And then the clang association is an interesting one as well, because you might hear it and you'll be like, how do I even try and summarize it into a nice sentence? Like the person might be saying clang bang sang, right? Like when they're speaking, and you're like, oh, it just sounds like a bunch of rhyming words, but it doesn't seem right. Like no one would normally say that, right? Is what you'd be thinking. Well, the way you can phrase that is that they have what's called a clang association, where essentially they're saying these similar sounding and rhyming words, and that is another example of a formal thought disorder, and you can link that up to different pathologies, which we'll have a look at later on. And then you have sort of problems with content. And usually at the year 2 level, we only focus on two main things. One is a delusion, and we'll talk about delusions later on because it's sort of also in the domain of perception a bit. So I'm kind of skipping back and forth here with delusion. We'll come to that in a bit. But delusion is basically they have a belief that is completely implausible, even in their frame of reference. So for example, let's say someone thinks that they are Cleopatra or they are, Albert Einstein. That's completely implausible and bizarre because those people have died, and so it's impossible. But let's say they instead had some other delusion, like they're like, oh, I work for the CIA, right? That's not completely implausible because it can be true, but it's not true for that person. They hold that belief very strongly, even though it's false. So that's the example of a non-bizarre delusion, whereas a bizarre delusion is something which is completely implausible. I hope that sort of makes sense, and we'll come back to it in the next slide as well. But that's the difference between a bizarre delusion and a non-bizarre delusion. And that's sort of, it becomes more important in the realm of schizophrenia, where a bizarre delusion might pop up there. And then you also have in the content things like suicidal ideation, which is something a doctor might screen for in a person. I think one kind of way you can screen for it is asking the patient, if there was a fire in this room right now, what would you do, right? And the normal response would be to douse the fire, run away, essentially try and get to safety or ensure safety. Whereas some people might say, I don't know, I might just sit there and let it, I don't know what I would do essentially, right? They might just let it rage on. And that would be an example of maybe someone who you might want to screen for further for other sort of things like, have they got any plans? Have they made any plans? And, further questioning. So it can be quite troubling to talk about for the person who is going through it, and also for the physician as well. So always keep a check of your emotions while you're having that discussion as well. And then you also have things with thought that can go wrong is alienation, right? So that's where you feel like your thoughts aren't your own, and that can be manifested in a couple of different ways. Like you can have what's called insertion occurring, where you feel like someone's like inserting thoughts into your head without you spontaneously coming up with them. Like you might have the bizarre delusion that aliens are inserting thoughts in your head, and you or like God is inserting thoughts in your head. Whatever the agent is, someone's putting thoughts into your head, and you're not having your own thoughts essentially. And the withdrawal or blocking is essentially where you feel like your thoughts are being taken away from you. Like you're thinking about something and suddenly you forgot, and you have this idea that someone's stealing your thoughts. And then broadcasting is where you feel like your thoughts are being broadcasted to the rest of the world. Like even though you aren't speaking what you're thinking, it feels like everyone else can hear what you're thinking. And the common way they describe this is like you might be listening to the television, and you feel like what you're thinking is coming up on the television, right? Which sounds a bit strange, but that can be a formal thought disorder that can actually happen, where it feels like your thoughts are being broadcasted to the TV, the radio, and that they suddenly aren't your own. They belong to the rest of the world through that medium. I hope that sort of makes sense. And that's going to be thought done. Now we come to perception, and we'll revisit the idea of a delusion here, because we'll be talking about three terms: hallucinations, illusions, and delusion, which all sound very similar. And when I first learned it, I was like, they just seem all the same, right? Like, what's the difference? Well, it comes down to a little bit of nuance. So hallucination is, simply put, there is no object. There's nothing stimulating you to sense something. So in other words, there's no real life object. However, you're sensing something there. So for example, if you're hearing voices, despite it yourself being in a completely quiet room where there's no chance for voices to emerge, that's a hallucination, right? Because you're hearing voices without any actually auditory stimulation. And you believe it's real. So even if someone tells you like there are no voices here, because it's a hallucination, it's not correctable. Like even if someone tells you there are no voices here, you'll continue to hear those voices. So an example of this might be hearing the dead, for example, right? Obviously, there's not going to be any sound of dead people speaking in the real world, but you're hearing those voices despite them not existing, and you're interpreting them as yourself hearing the dead. And even if someone tells you, oh, the dead aren't speaking to you, you're probably just, probably something you're just hearing yourself and it's not real. You don't believe them. You feel like it's really happening to you, and that either, God is speaking to you, dead people are speaking to you, or whatever else is speaking to you. That's an auditory hallucination. You can also have visual ones as well. Like you might just see a random thing that doesn't even exist in the real world and interpret that as being a real thing that's there in front of you. So there's no object, but you're interpreting it as being there. And even if someone tries to say, no, it isn't there, you're unable to shake it. And I think auditory hallucinations are the easiest ones to understand, and therefore that's the one they sort of emphasize as well. And then you have illusions as well, right? Illusions are incorrect perceptions of a present object. So what that means is now you actually do have an object, but you're just misinterpreting it in a bit of a incorrect way, but you can usually correct it as well. So it's an illusion in that sense that you can correct it once you discover the trick, right? Kind of like a magic trick. They're often called illusions because you think that something's happening in the trick, but then once they explain it to you, suddenly it clicks that, oh, this is just me having an illusion. And in reality, there's a rational explanation behind it. An example of this is like when you go to sleep and then the lights are off and you can see a shadow in the corner or a jacket in the corner, and you interpret that as being a person there, right? You know, that terrifying feeling you have at night. Um, that's an illusion because normally you can turn the light on, see the jacket, and then go back to sleep in peace, right? But it's an incorrect perception of a present object that is correctable, and therefore it's called an illusion. Same with a magic trick or a card trick, right? It looks like, you know, someone's able to just know what's in your head with which card you chose, but that isn't the case. It's usually some sort of sequence of steps. They've, you know, put their finger into the deck to be able to know where your card is, or done some other handling of the cards that enables them to find your card. So that's an example of an illusion, and I hope those examples give you a nice way of remembering them as well. The important thing here is that they're correctable, is to keep that in mind. A delusion sounds very similar to an illusion, right? It sounds like the exact same thing. But delusion is something where the person is deluded and they can't be corrected, right? So an illusion is where you reveal the trick, the person's like, oh, it's just an illusion. I get it. It works that way. Delusion is where they remain adamant and they have that conviction that, no, you're not right. What I'm seeing is right. So there's so many examples that you can give here, right? With the delusion, they might, you know, have a very bizarre delusion, like we said before, like thinking that they're a dead person, that I am Cleopatra or I am Albert Einstein, or something like that. Or it could be a non-bizarre delusion where it's more plausible but unlikely. So, you know, things like saying, you know, they're trying to poison me, or um, they're they're putting chips into the vaccine might be a bit of a non-bizarre delusion because it's possible technically, but it's unlikely, and it's a delusion that's held very strongly by that person that can't be corrected. Therefore, it doesn't fall into the realm of an illusion. It forms into the realm of a delusion. I hope that all made sense, and I've got some diagrams down there that hopefully can make that a bit clearer. But do keep this in mind because they can often ask you about the differences between those in a multiple choice question as well. And then we come to the final few bits: insight, judgment, and cognition. So insight is basically whether a person is aware of their illness. So, you know, if a person is expressing or showing signs of depression, right? And they're aware that they have depression. They might say, you know, I have been feeling a bit down lately, and I think I need help. That's called good insight. Whereas if a person's like, I don't know what's happening with me, I just feel like I'm just confused and there's no clue what's going on. That's an example of maybe a poorer insight into what's going on with them. They are aware that something is wrong, but they don't have an entire awareness of what is wrong. And so that's an example of a lack of insight. And usually you can see that in the form of whether they're aware of what they have and also the need for treatment as well, right? If a person doesn't see the need for treatment and wants to sort of just leave and not come to the doctor, which often can happen in an interview where it's like, I don't know why my GP sent me here, right? I think I'm fine. That's an example of a poor insight. And then judgment is the ability to essentially problem solve and figure out next steps. So if you ask them, what's your plan once you leave here? And they're able to show to you clearly that, you know, they're going to be able to follow up with whatever treatment you've given them, have a chat with maybe a GP afterwards. That's an example of good judgment and good insight. And you can test it in other ways, but then if they show a lack of that, it'll usually be quite obvious, and you're able to comment on that here as well. And then finally, you have cognition. Cognition is something which you usually don't formally assess in a mental state exam, because as we look at in the next slide, to test cognition is testing all the different lobes of the brain if they're intact and if they're functioning. And that usually requires quite a long multi-step process or a questionnaire. So you will normally not formally assess that. Instead, what's most commonly done in the hospitals, where, you know, you're seeing multiple patients all the time, or in a sequence or in a row, is you can indirectly test cognition very briefly by asking the person, hey, do you know who I am? And they'll be like, you're a doctor. Do you know where you are? They'll be like, I'm at Monash Children's Hospital, or I'm at the Alfred Hospital. So that's oriented to place and person. And then you might ask them, you know what the day is, the month is, the year is, or you might start off with the year, then you will go to the month, then you'll go to the date. And that's oriented to time as well. So if the person is oriented to all three, you'll just say they're alert and oriented to place, person, and time, right? That's a simple way of testing cognition. And that's a way of doing it informally. But you can also do it more formally with the mini mental state exam, which is a formal checking of cognition, which we'll come to in the next slide. So here is just a summary of everything we've discussed. So in reality, when it comes to mental state exam, you're not going to be performing it yourself. Usually you'll be watching a video of someone doing it and then commenting on the findings in the video, because doing it or asking the questions at the same time as being able to interpret the responses is quite difficult. And so you need time to develop that. So you start off by just watching the interview and being able to understand what's going on and then reporting the findings. So one thing that I found useful was trying to make a little script of what I could potentially discuss when it comes to a mental state exam. And that's sort of what's on the screen here. So you might start off with, today I observed the GP or whoever it was performing a mental state exam on patient's name and the details. Details might include things like, you might say, whatever's in the stem, like a 25-year-old farmer, right? 25-year-old male farmer might be what you say. I was performing a state exam on John, a 25-year-old male farmer, on appearance. And then over here, you could comment on things like clothing, makeup, posture, hygiene, whether they're shaved, whether they're well-groomed, their gait, and their possessions, right? Possessions might include things like a cap. They might be wearing it the right way around, the wrong way around. That can be something you comment on as well. If they're wearing a watch, it might seem completely irrelevant, but then it shows like the level of attention and care they're giving to themselves as well, which can be linked with certain pathologies. Like if they're wearing possessions the wrong way around as well, that can again be linked to pathologies, like they might be in a rush even. But it's good to comment on it rather than leave it out, because you do have the time to be able to comment on it usually in this context. And then with their behavior, you can say in terms of their behavior they demonstrated, and then talk about social manner, eye contact, whether they were responsive to your questions, whether they had psychomotor retardation, agitation, on the general demeanor as well. Like, do they seem quite shaken? Do they seem, less willing to talk? Their breathing pattern sometimes is important. Maybe they're breathing very heavily, which might indicate they've got some sort of lung disease, which might seem like it's out of the realm of mental state exams. But remember, a combination of factors affect your mental well-being, and so breathing pattern could also be important here, and expression as well, like the expression on their face might also be relevant here. So all can be commented on in this part. Then you might say something about their speech. So you would say their speech was, talk about the production, dysarthria, prosody, which is like sort of the melody and intonation. So in things like depression, you have a loss of prosody because the person becomes quite monotonous and uninterested with what they're saying. Then you have things like speed and rate of speech you can comment on, volume, quantity. We talked about this before as well, whether they're fluent, understandable, whether they're impoverished or in poverty of speech, which is essentially saying that they're not speaking as much. They're speaking with very few words, which again is linked with things like depression, right? Where you're very uninterested. And then spontaneity, which is where they're able to respond to you quite spontaneously and regularly, or latency, where they have a bit of a delay or a lag between hearing what you're saying to them and then responding to you, which might indicate a couple of things. One, the question itself might be quite complicated and hard, and they're having to think about it. So that's quite normal. Or it might be abnormally long latency, where the person has a cognitive issue and is taking time to really interpret what you're saying and then form a motor plan for how they want to say it, right? And then based on general evaluation, you might say their affect is likely blah, 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 blah. So that's where you give your evaluation of their emotions. So things like, are they depressed? Are they anxious? Comment on the range, intensity, severity. Labile is whether it's like changing a lot throughout the interview. Like you might see them, at the start of the interview being very happy and then suddenly falling into like a burst of tears and then suddenly looking very angry. And so they're very labile in that sense, right? Or whether it's appropriate to the thought content. Like if someone is speaking about some very depressing and harrowing themes, but then they have a grin on their face and they look like they're very happy, that's not very congruent, right? So that's an example of inappropriateness to the thought content. And then when you can go on from there and say, upon questioning during the interview, they describe their mood as blah, which is where you would say what they describe their mood as, depressed, anxious, whatever, and you can actually like, quote them on the actual words used, which is the best way of doing it. And then you can just comment on whether that's congruent with the affect or not, which usually will be in most of these scenarios, or actually might not be in the case of a person who has poor insight. And then you say that things like there was no evidence of perceptual abnormalities, or there was evidence, and that might be things like hallucinations, illusions, or delusions. Or the delusions you might include in thought content as well, or the thought section, and it doesn't really matter, but totally up to you, as long as you include it somewhere. Their thought stream as well, you can mention was whether it's slow, normal, increase, and again, that's based off their speech. And we talked about how that might not be the case in some scenarios where they're speaking very fast, but not necessarily thinking very fast, and therefore they have some incoherence to the speech. Talk about the form, whether it's normal, linear, logical, organized, goal directed, which is all ways of saying that they have pretty normal form, or is there evidence of a formal thought disorder? So things like flight of ideas, where it's hard to follow derailment, where they're having loosening of associations, where each question or each response to the question is becoming more and more irrelevant as they speak more and more. And circumstantiality, we discussed those terms: tangential, word salad, clang associations, neologisms. Asyndesis is where the connections between thoughts are lacking. Metonyms is where they're using a word, but they're using it in the wrong context or incorrectly. So you might be able to pick that up very obviously, where you're like, why is that word being used? That isn't really what it means. And preservation as well is where they're just stuck on a thought and they're not really able to move on from there. As well, thought content, we talk about whether what they're actually thinking about, like the themes of what they're speaking about. Is there depression or sort of like suicidal ideation? Is there delusions? Are the delusions bizarre? They might be having a delusion of persecution, like they feel like going to the doctor and being asked to see the psychiatrist is like the doctors are all just ganging up on them. They have that delusion that everyone is trying to sort of persecute them or punish them for something. And that's an example of a non-bizarre delusion, because again, it could be possible, but it's unlikely. But it could be also a bizarre delusion where it's completely implausible, right? And we talked about that before, where it's like, God is speaking to them and giving them instructions on some random side mission that they have, which technically might actually be non-bizarre within their frame of reference, but also arguably is considered a bizarre delusion as well. It's a bit debatable. You can have a chat about that with skill shooters. And then there's also things like thought alienation. Is there evidence of that? And so you can say, is there normal thought possession, or is it things like blocking, broadcasting, insertion, all those things? And then also suicidal ideation. If they talk about it in the question, you can say that there's evidence of it, or if there's no evidence of it, you can say there's no evidence of it. Simple as. Cognition, again, will normally never be formally assessed. We'll talk about how it can be formally assessed in the next slide with the mini mental state exam. But if it isn't formally assessed, just say it wasn't formally assessed, because in most cases it won't be. In your OSCEs, it definitely won't be, given your time restrictions. But you can say it appeared grossly normal because they were alerted to place, time, person, whatever. Or if they don't have that, you can just say it appears grossly normal because there isn't sort of any indication that the cognition is lost. And then their judgment or insight seemed either intact or impaired, and you can explain why as well with actual reasons. So I hope that gives you a better idea of how to approach the mental state exam for your OSCEs. And I hope the scripts can help you guide you develop your own way of thinking and speaking during this OSCE as well. The next slide comes to the actual clinical correlates. Like I've told you a bunch of different elements and what you might expect to see, but then what is the point? Like, why are we learning this? And in reality, at the year 2 stage, you're not expected to be able to diagnose anything complicated. But I thought I'd take this page out of, I think it's a 4th year presentation that was on mental state exams, because I feel like if you just taught to say a script, but then aren't actually explained why it's important, it becomes kind of less relevant for you. And so hopefully having a look at some of these things here can kind of put it all into context. And you don't have to know it, word for word, but I think some of the things here are kind of obvious. So in depressive disorder, right, major depressive disorder, you expect things like poor self-care, maybe changes in weight, signs of deliberate self-harm, psychomotor retardation. They become quite uninterested, slow, poor eye contact, depressive mood, obviously. The affect is blunted, flat, loss of prosody in their speech. So like we mentioned before, they have lost that intonation. They're quite uninterested in the way they speak as well. And there's so many things you can look into there. Suicidal ideation is a big one you have to screen for. And often things like cognition are intact, although they might have like impaired attention, right? Insight, they may or may not have it. Judgment, again, if they're very like severely depressed, it can actually impair the judgment to the extent that they won't be able to think for themselves rationally as they normally would have, right? So that's major depressive disorder on the left there. Then we also have schizophrenia, which is, again, it's a complex one to approach, but here's some things that you can sort of keep in mind and really use to guide you as to why we even care about these elements, right? So with schizophrenia, that you see things like, signs of poor self-care, disorganized behavior, odd posturing, suspiciousness, aggression. There's quite a few things there. I think let's go to some more important ones, which are in thought form. You can see things like disordered thoughts. So like that's a formal thought disorder, tangentiality, loosening of ideas, where they have these really strange delusions. They can often be quite bizarre as well, and bizarre with the way we described it before. And that is pretty a good indicator that the person might have schizophrenia. They could also have hallucinations, auditory ones especially, and they might have command hallucinations where they're being instructed to do things as well by voices, for example, which is often the type of ones you'll see in interviews at this stage, at least. Cognition-wise, again, you never usually formally assess it in a mental state exam, so you don't have to really worry about it, but they might have impaired cognition for some of the tests. Again, insight will be quite poor because they have that fixed delusion and they don't really see past that. They're sort of convinced and they have that really strong conviction and they're adamant that they're correct. And then judgment would also be impaired because of that delusion, and they might be almost entirely consumed by it and not be able to think rationally. Yeah, so that's schizophrenia. And then the last two, bipolar disorder and generalized anxiety disorder. I think that the last one, there's probably more important. Anxiety, just generally being able to know what that looks like. Often you'll see that, in the way they're speaking, in the way they're posturing. They seem quite anxious and stressed. They're often think quite rapidly as well because they're like thinking about so many things at once. They're anxious. And in terms of other things as well, yeah. So thought content wise, you might often see that they have very clear practical worries about something with their anxiety. They're worried about a test. They're worried about the pregnancy. Anything that could come up over here could be the cause of their anxiety. And otherwise, the rest of the stuff there is for you to have a look at. And bipolar disorder is, again, so like it's like very big fluctuations in a person's mental state, and it's marked by episodes of psychosis and then a drop as well. And so there can be quite a few indicators of that. So it can be like sort of very euphoric or sort of irritable as well, and that sort of depends on what sort of point they are along in that sort of their mood. So it's quite labile is essentially the main thing is like the affect, rather than being sort of constant and pretty like sort of fixed, as you'd expect with most cases, and rather than being responsive to changes in the circumstances, they are sort of change on their own and very rapidly and go through many upside downs and like a roller coaster. And so we call that quite a labile affect. And the rest of it is, again, there for you to have a read, but not important for you to necessarily memorize, because I put this here again for your own interest to be able to see how you can link this in with certain conditions. So don't worry about memorizing it. Often it'll be obvious that a person has one of these. Depression and anxiety will be things you'll be able to just like identify pretty well because of the content and the way they're talking to you. But again, it's not a definitive diagnosis. It's sort of just a constellation of symptoms that points towards something. All right, then the mini mental state exam. So this is not the same thing as a mental state exam. It's called mini, but arguably it's a bit longer. because you have to go through an entire questionnaire with a patient. Not to say that the mental state exam can be long as well, because you might have a very long chat with a patient, but a mini mental state exam is essentially a scored questionnaire where you're testing the person's cognitive function. So importantly, it's about cognitive function. It's not about what the person's thought content is, what their emotions are, the whole mental state exam spiel. It's a mini version of it that focuses specifically on cognitive impairment, right? Testing a couple of lobes through this section, and I'm not going to focus on like what each of the lobes are and what they correspond to, because I'm sure you can search that up and see that in your slides. It's just a bunch of things you have to just know. But the way I sort of thought about it is temporal lobe is sort of more to do with memory. And so impairments in memory and knowing where you are and things like that, knowing who's in front of you comes from memory, and that's sort of the temporal lobe. The frontal lobe is more for executive function and sort of following instructions and carrying forward those instructions. Parietal is more the sensory integration with visual-spatial sort of tasks. And examples of that is like, what's a good example on there? Like naming a watch and a pen, where you're taking that visual stimuli and being able to name what it is. Writing sentences, so that's sort of visual-spatial component of it. And then copying intersecting pentagrams. So you can see over there on the bottom, there's like sort of two pentagrams or pentagons in the way they have to sort of draw it. And if they're unable to draw it correctly, it could be a parietal lobe issue. Again, I don't think you have to know too much about it, but just know that essentially we're testing cognition and testing the function of lobes that are associated with essentially giving you that cognition, right? In terms of why it's important, well, if you see a constant decline in someone's cognition, right, a very progressive decline, that can indicate dementia, because dementia is a condition where cognition and memory is impaired, but what's called arousal is intact. So the level of consciousness is not impaired, but their cognition is impaired. So they won't like sort of just drop out of consciousness chronically. It's more so to do with their cognition declining. Delirium is sounds similar. Like you might think someone's delirious and that is that the same thing as dementia. It actually isn't. Delirium is more so to do with sort of, rather than having a constant progressive decline in cognition, it sort of fluctuates. So for example, someone might have a very severe infection, like a UTI, like you might have learned about, and that causes delirium in old people, if you remember, because what happens is you can get sepsis, and that sepsis can cause delirium, which is, again, sepsis is where like the bacteria goes into the bloodstream and then causes havoc throughout your entire body. And that's delirium, where you have fluctuations in your cognition, whereas dementia is the constant progressive decline, right? Hope that sort of makes sense. And often I think they use the word sundowning, which is where, the symptoms might get worse at a particular time during the day and then improve. That's delirium associated, I believe. But that's again not too important to know. Just I think it helps to know why we even do this test. And schizophrenia, as well as and anxiety and depression, is where you might expect to see cognitive impairment. Anxiety and depression, less cognitive impairment and more sort of impaired concentration, where they're unable to do some of the things on the test because either they're so anxious about something or they're uninterested that they're unable to focus on the task at hand. So it's less true cognitive decline and more sort of an impaired concentration. Now, what should we take away from all of this? Like, what's actually important? I'd say the cognitive domains on the top right there are actually important. That's the stuff that you have to know for your odd MCQ question, where they'll describe some phenomenon, a patient's circumstance or a scenario, and they'll ask you, what cognitive domain do you think is affected? Is it attention or concentration? And again, attention is sort of a more passive thing, is like where they're able to sort of fix their attention at a particular point or a particular person. Concentration is more actively making an effort to listen to what someone is saying and try and develop a response towards that. So that's the sort of difference there. So, eye contact is, I guess, more attention, and concentration is more like how intently they're listening to you and then able to respond with a relevant response, right? And then praxis is all about motor planning. And then constructional practices, things like being able to draw the pentagrams or actually draw a clock face and then be able to draw the numbers on a clock face. If they have an impaired ability to do so, that's an impaired constructional praxis. Whereas dressing practices, things like being able to button up their shirt. If they're unable to button up their shirt, that's an impaired dressing praxis. Expressive and receptive language. One is where you're able to express yourself and speak, One is being able to understand what someone's saying. And so that's two types of cognitive domains that can be impaired. Long and short-term recall. Short-term recall is where you give them three objects to remember and then ask them afterwards, what were these objects? Long-term recall might be you tell them about three things to remember for that particular day, and then you tell them we'll come back in a week and then or come back in another day and then recall it, see if you can remember, which is often tested in a person you suspect cognitive decline might be happening in. That's long and short-term recall. And the last one that we've already covered, orientation to time, place, and person. We talked about what that was and what that means as well. Registration is not too important, so I won't cover it there. And then that's basically it in terms of the content. I've just compiled what I thought were useful resources. The first one there is so valuable. I wasn't affiliated with SciSom at all back in year 2 or year 1, but I remember going onto the Moo Drive and just typing in mental state exam and then finding this very useful resource there. They've got all the terminology there. They've got the actual components of the exam. And they've also got, besides summary sheets, actual POS keys for you to practice with, which is so useful. So they have the YouTube videos of the interviews you can find online, but probably more usefully, they actually have suggested responses as to how you might be able to respond to the examiner in the interview regarding what your findings are for that particular interview. It's so useful. So I've bolded it there as well. Take a look, please. My script is based off what they wrote in there. I found it invaluable. So I hope you find it useful too. Then practice exams wise, they do have stuff on there, but I think it's more geared towards 4th year and 5th year where your psych teaching becomes a lot more important. So I wouldn't worry about that too much. Instead, in terms of questions for what you might expect in the exam, have a go at some actual practice exams and you'll see your odd question here about cognitive domains or mental state exam elements and what they mean, and being able to link a particular circumstance or scenario with the associated mental state element, like anxious mood, depressed mood, flight of speech, pressure of speech, or flight of thought and pressure of speech, or being able to link the cognitive domain being affected with a particular presentation. So for example, a person is unable to button up their shirts, linking that with dressing praxis. And then as well, there's an article there you can have a look at. Wikimedic, as always, very reliable for this kind of stuff. Have a look on there. That's sort of more on how you would actually go about being the person asking the patient questions during a mental state exam. But in reality, you won't be asking the questions in your OSCE. You'll be the one listening to the responses when a GP is asking the questions. So it's more for your own personal knowledge and more for you to be able to get your way through the clinical skills sessions, but not necessarily that useful for the OSCE, if that makes sense. And then over here as well, I found this nice little summary diagram. It's a bit much because it's, again, a bit crowded, but if you want like a nice little infographic that puts it all together, here it is. And credit to whoever made it. I don't know where it's from. I think it was just on the internet. It's just Francis Acton. Whoever made it, they did a really good job of putting it all together. You can have a look on there and see how to piece everything we talked about into one nice formalized framework. So that's all done for today. I know it was quite a bit. I tried to keep it very relevant for you and your OSCEs and your exams. And if you do have any questions, concerns, or feedback, please let me know. And I'm more than happy to sort of give you my best understanding of how to approach that. But otherwise, I'll leave you to it and we'll see you in the next one.